we'll see what that shakes down to be once I get to see the test. Ms. Johns hasn't sent a copy of it out to the rest of us yet, so I haven't even gotten a look-see at it yet. So from looking at the communication material, what was your takeaway as the most important thing? Why do we have to talk about this, and why did I drag myself in here when I could have stayed in bed to talk about communication?
Communication between patient or between health workers, like
Okay.
everything.
All right.
It's important because you need to have a good teamwork, like consistent care
Okay.
from shift to shift, and then meeting goals of the patient and providing a good plan of care.
Okay.
So just a few.
What else? If you think about it, Krista's question was a communication question. We need to know exactly what that test question was trying to communicate to us so that we can answer it. So, unless you've got your communication on lock, there's going to be major issues in everything that you do in your nursing career. So who do we communicate with?
Everybody.
Coworkers,
Patients,
patients,
doctors.
doctors,
Patient's family.
family, that's a big one. Angry family, like a little mob will come at you with sticks and stones. Ah. Who else?
The healthcare team.
Okay, who else is on the team?
That's the case manager,
Okay,
physical therapist,
okay,
dietitian.
all right, keep going. It's a village,
Yeah.
you know? A care setting, no matter whether it's a hospital, an LTAC, a rehab, it's a village, and you have to be able to communicate clearly and effectively with every person you interact with so that things don't get screwed up. Because at the end of the day, who's responsible if things get screwed up?
The caregiver.
PRN. You're where the buck stops. You are the patient's defender. You are the person who's responsible for making sure that everything goes safely and in a timely manner. So if you're not communicating effectively, stuff's gonna get missed, people are gonna get angry, patients are gonna die, you're gonna lose your license. You ain't even got a license yet. We're already worried about losing it. So you can tell that this is a really important thing to talk about. So this is perhaps not one of the more entertaining slideshows that they made for us, but it is a lifelong process. So have you learned anything about communication since your first day of nursing school?
Yeah.
Y'all are really struggling to come up with a yes to this one. Have I? What have you learned?
Like for one, it's like the use of S-bar. S-bar is a good.
Whoa, you
There
are
go.
you are the
Pull
top
out the
student.
clutch. Love it. So you've learned a standard format to make sure that you don't let things fall through the cracks. S-bar is there to have your back, to make sure that you give all the information that you need to and don't leave things out. That's the point of S-bar. It's not just because we wanted to come up with something extra for you guys to learn. It's because we're trying to help you have a way to not forget the important things to communicate. So, yeah, you learned S-bar. That's a good thing. What else have you learned about communication? At this point, everyone uses to make eye contact.
Like communication between the ongoing nurse and the outgoing nurse.
Shift report. Have y'all seen that take place?
Mhm.
Was it like what you thought it was gonna be like?
There's good and there's bad.
Yes.
And there's horrible.
There's a range. I've worked with people who would give an incredibly fabulous detailed report down to, you know, cranial nerve assessment and do it concisely and brilliantly and do an amazing job. And I've worked with people that say, this one's a whiner, this one's a puker, this one just needs to go home. Thanks, Norma. Good to see you too. What's important to make sure you communicate at change of shift? Because this is a crucial time. What do you need
Anything
to
that
communicate?
happened through the night
Okay.
or happened through your shift. 'Cause
Changes.
yes. And anything that's due immediately that might be coming up as soon as we switch off.
Somebody just wrote an order for a 7:30 antibiotic, and I should probably tell you about that instead of letting you find out at 9 a.m. when pharmacy puts it in and it's flagged as late. Oops. What else?
I think that
The patient is
anything.
at full risk.
Okay, safety issues. You got something
Well,
to do
I
now?
guess any change that took
Okay.
before the shift change should
Okay. Silent wall. Your turn, ladies.
Using therapeutic communication,
Okay.
like using active listening, silence, reflecting.
Y'all are working the hell out of the active listening and silence. Right?
Yeah.
Tell me more. How about how the patient emotionally is doing? You can give me a report that's clinically focused and straight down the line. And my patient may be emotionally stable, emotionally unstable at this point. And a lot of that's due to the communication that the previous nurses had with them. What makes patients feel comforted and safe?
Like if they feel like the nurse has a real connection with them,
Okay.
and like talking to them, like not just like standard checking on you, but they can really feel that they are with you, like aside from providing.
How do we
usual
make them
stuff.
feel that?
Talking to them.
You just take time, like 2-3 minutes, just sit down.
Yeah.
look at them
Ooh,
and
sitting
talk.
is a big part. You know, I love to talk about studies. They've done a bunch of studies that show that if you stand next to a patient for the exact same amount of time that you sit down next to a patient, in the patient's estimation, they double in their mind the amount of time that you spent with them. So it seems like you've been there twice as long as if you stand there, because standing is perceived by patients as being rushed and disconnected. Huh. Okay. So, having a connection with the patient and providing them knowledge are two major parts of communication. Have you ever been to the dentist, the doctor, an appointment where you feel like your question kind of got brushed off and you're not sure what's going on and people like just here's your papers and go away? Yeah, I have.
Like I mean, for me, I always ask like, what's this for? Like,
Mhm.
what does this do? Like before nursing school, like
Do you ever get that response?
yeah.
How does that make you feel?
Well, I think I'm supposed to know what you're giving to me.
Well, yeah, you're supposed to know what they're giving you. Do you feel supported if
Well,
somebody
if I get that
rolls their
reaction, I
eyes,
don't.
gives you the sigh?
I found one thing, back in the day when I was a physical therapy technician, I used to, in the Army, I was allowed
You're
to.
so old.
Yeah, well, yeah, I'm getting up there. No, but when I would have, I found that whenever I have a client, because I was allowed to do the whole episode, you know, and but the more, rather than telling them to do a certain exercise, I would explain why you do it. I'd watch them do it, and you find that those clients are more prone to do something if they know why they're doing it. What they tell you to do? Well, they told me to do this. What is that for? I don't know. They told me to do this. So same approach with nursing too. Is like, as a student, when I work with clients in the hospital, I'm talkative. I tell them everything.
Yes.
I ask them questions. They ask me questions. If I don't know, I'll talk to the nurse. I try and get engaged with them, you know, as much as I can, and the family involvement if I can too. So yeah, the more that you do that you build they're more comfortable with you. They're more
Yes.
accepting of you. Their heart rate
Yes.
goes down. They feel more comfortable. But that's what I learned, and I just transitioned that to what I'm doing now, or trying to do now.
If you understand why you're supposed to do something, it becomes more palatable. If we explain to you why class is canceled on short notice because I can't stop barfing, it's more understandable than just we're not having class today. Get out of the toilet. You probably don't want to catch what I have. Does that make sense? Okay. I gotcha. I'd rather not be barfing too. Fair enough. So especially with painful or uncomfortable things, if you get the client to understand why it's important for their recovery, for them to do this thing, they are far more likely to be cheerful and compliant with it. God knows, incentives flounders. People go in, tell the patient what to do, they dump it on the nightstand, and they walk away. And you go in and ask the patient, are you doing it? No. Why not? Well, I don't see why I need to bother with it. It doesn't make me feel any better. Okay, no, it doesn't make you feel better right away. That's not the point of it. It actually usually makes you feel worse. Because the people we're asking to do that are people who've got pain that's limiting the amount of breathing that they're actually doing. But if you take the time to communicate to them, hey, this isn't just a torture device. If you don't take deep breaths, then the bottom of your lungs stick together and bacteria like to grow there, and you might get pneumonia, and you might spend another 2 weeks with it in the hospital. People are giving that thing hell. But it all comes down to communication about why. So, does that help you reframe your whole shift at clinical? I mean, that's your job as a nursing student, to be really the one that goes in and tells them, this is why we're doing all of these things. And if you have a question about why we're doing anything, ask me. And if I don't know, I will get you the answer. Because knowledge is power. And we can't expect that patients know anything going in. Some patients are very knowledgeable. People with chronic conditions may know a whole heck of a lot about what's going on. But people with acute conditions are usually bewildered, confused, lost, and frightened. And the way you make that better is by communicating. So communication with patients is a huge part of nursing communication. But then there's all the other people that we have to deal with, and they're kind of important too. And that goes back to building relationships with everybody else. So, have you had a family member try to collar you in the hallway or outside of the room yet and ask you questions without the patient there?
Yeah.
If you haven't, it's coming. It's going to happen. What are you allowed to communicate to a family member or friend?
Especially you have to be sure if the friend or the family member is supposed to get any information.
Okay. You need to know if the patient wants them to know.
But some of them can be sneaky.
Oh, yes. Oh, yes. There's a lot of sneaky people in this world. There sure are.
Especially when it comes to the phone. I'm the daughter. So you have to make sure you join the chat to see you're supposed to get the information.
It's so easy just to be
Oh, but they make you have a code. There's a code. You gotta tell them the code.
Yes.
There's an old nursing joke. That switchboard gets a call. Says, oh, hi, I'd like to check on the patient in room 321, Miss Williams. I just want to see how she's doing. Oh, she's doing really well. Her operation went great. Things are doing better. She's probably going to be discharged in the next couple of days. Oh, well, that's great to know. Thank you for telling me. Oh, can I tell her who called? Well, this is Miss Williams. Nobody tells me a damn thing. So, if you don't tell the patient what's going on, they feel helpless. Family members will start to come poke at you for information. And the one thing I really want to extra special caution you about when speaking to friends and family members is remembering that while you may know the patient's entire medical history, that does not mean that friends and family know the patient's entire medical history. And you have zero right to divulge any of that without the patient's permission. Because there have been many times when family members have been told by accident that a family member has herpes, Hep C, HIV, and the patient was keeping that information private. That's a flaming HIPAA violation. Flaming HIPAA violation. What happens when we violate HIPAA?
You can get sued.
Mm-hmm. Is it the worst that happens?
Your license will be suspended or revoked.
Yeah. I have a very good friend that was a nurse for almost 40 years, and she got involved in a situation where she accidentally divulged something that the patient didn't want divulged. She was fired from her job. Her license was revoked. She had to retire about 10 years earlier than she anticipated retiring. And this is someone who had been cautious for 40 years. One moment off your guard is enough. So you've really got to watch your mouth. One of the easiest ways to do that is reflective questioning. What does that mean?
You rephrase the question of the other person.
Okay.
Like, can you tell me how the patient is? Oh, are you do you want to know what the patient wanted? Like, rephrasing
Okay.
what's being asked to you.
Sure. Are you asking about her pneumonia and how that's going? Or tell me what you know and what questions you have about that. And let's go and talk together. You can never, ever, ever get in trouble with the HIPAA police by saying, let's all talk together, and moving that conversation back into where the patient is and making sure the patient's okay with any information. Patient Jane. Jane, your aunt's, concerned about how you're doing. Are you okay with us all talking together about how you're doing? Jane has the option to say yes, no, and you can always throw that, or would you like to talk to me for a moment privately first? And that gives the patient an out to say, this is what you can tell them, and this is what you cannot tell them. Make sense? Okay. I don't want anybody to get busted after leaving my class for running their mouth. So, when we think of verbal communication in nursing, who do we talk to mostly?
Other nurses.
Mostly you should be talking to your patients.
No.
That should be your number one. Other nurses number two. The majority of your talkie should be with the patients. Why are you shaking your head, Krista?
Well, if you work in labor and delivery, most of your time is going to be talking to your fellow nurses. I'm telling you, this is horrible.
While you're sitting around waiting for somebody to have a baby?
Or not have a baby. Yeah. It's boring.
Yes. It's boredom interspersed with random bursts of terror, essentially. But that doesn't mean that you can't be in the room with the patient talking to them.
But why would you want to do that when you can just sit there and do nothing?
Because you don't want to be a sucky nurse.
True.
Why go through all this trouble and get a license to do something that you don't want to do well? At the end of the day, that's my question to all of you is why bother if you're not going to do it right? So, your primary verbal communication should be with your patients, then with nurses and the other team members. So, what's important about how you manage your verbal communication?
You don't want to, like, I guess with clients, you don't want to doctor speak them.
Yeah.
You know, I think you want to.
Well, Rob, it seems incredibly obvious that your uvula is deviated towards the lateral side of the medial septum.
Exactly, you know, and
Yeah.
that's one big thing. My personal experience when I go to the doctor's office, like they're taught, like, okay, so what are you trying to say?
Mhm.
You know, and again, it goes back to that understanding. You know, you want to make sure they understand as much as possible.
Don't you understand? How many times do I have to tell you this?
Yeah, or you can rephrase if they don't get it, then just rephrase it in a simpler way. You can break it down more. You
Okay.
know? Basically, is what I'm saying. Is,
It's the words you choose. It's the volume you deliver them at. It's the facial expression you use. It's the tone of voice you use. And it's standing or sitting. So, if I walk into your room and I say, why are you still in bed? You know that you're supposed to be up and walking for 15 minutes. Get up and walk.
Okay, you can go right back out the door and come back later.
Uh-huh. Do you feel like getting up and walking right now? You
I'd
feel
be
like
like,
getting up and punching right now. But do you feel like doing what I've asked you to?
I'm not going to do anything you say today.
Yeah, probably not. Hey, Krista, I noticed that you're still in bed, and one of the goals for today was to get you to walk. Is there something we can do to make you more comfortable right now so that we could get up and take
Can
a
I
little
get my
walk
pain
together?
med?
Yeah, absolutely. Can you rate your pain for me?
It's like a 6.
Okay, how long have you been hurting like this?
An hour.
Okay. Next time, don't wait for me to come to you. Ring your call light. Let us know. We're happy to bring you medicine. Go get your pain medicine. We'll let that start working. And then we'll take a little walk together, okay?
Yes.
Great. Okay, so would you be more interested in complying with the first me or the second me? How many of you have encountered the first me in hospitals?
at the rehab we did last semester.
Oh, that was horrible.
Whatever that place was.
Those nurses,
That's
Heritage Manor.
the assistant, the techs.
Heritage Manor.
How they treated them.
Yeah. My terror in life is to be elderly and incapacitated and at the mercy of people who work in these places. So, if y'all see me someday, please just quietly put me out of my misery. Don't make me live there. My whole family knows. Just do away with me.
But you know, it's kind of scary though that lots of people in there are doctors. They're,
They're professionals.
yeah.
You still get old and you still get sick, no matter what your job was. And you're still helpless at the hands of people who may or may not give two shakes about how you feel. And that's something that the goal of nursing school is to drum into your head. It doesn't matter what you see other people doing, you yourself are responsible for communicating as a professional. Just because Johnny does it doesn't make it okay for you to do it too. If I teach you nothing else, please let this stick. Nonverbal communication. Really? But you see it, don't you? Do you see your nurses when you go to clinically treat you that way? Yeah. How does it make you feel?
Sorry for the patient.
True, you get to leave at the end of the shift and the patient just has to stay. I found that one of the things that helps a lot in life is to remind yourself that you really can do anything for 12 hours. You really can. No matter how bad it is. You can get through 12 hours of it and then you get to walk out the door. And I've saved my sanity many times. Just keep an eye on the clock. Okay, now I only got 10 more hours of this to get through. Okay, I can do it. I can do it. I can go hide in the bathroom when I need to. Personal appearance and grooming. This is a big one. Did you ever wonder why you have to wear a uniform to nursing school? Is it so we can like pick you out in the hospital and be like, ooh, that one belongs to me?
It's part of being professional, like professionalism.
Yeah. Do patients inherently welcome someone with open arms when they say, hi, I'm a nursing student? You've already got a strike against you. Nobody wants to deal with a student. Nobody wants that experience. So if you go in and you look sloppy, like you just rolled out of bed, and you smell like cigarette smoke, and we can see all 87 of your tattoos and 43 piercings, and your little horns you had surgically implanted, and your elf ears and whatnot. Do you look like somebody whose primary interest is really nurturing and coddling and taking care of you? Not necessarily. So we do everything that we can to make you look like someone worthy of confidence when you walk in the room. So we want you to follow the rules so that you're well groomed, you're neat, you're appropriately dressed. You don't look like you sleep in the stairwell of the hospital and just wander in for snacks. You see staff come in looking like that. Do you get excited when you get paired with a nurse who looks like 3-day-old leftovers? What's your first thought about how that shift's gonna go? Oh, crap. Right? Does it mean that you're not capable of being a caring professional if you have 18 piercings and 39 tattoos?
No.
Absolutely not. But first you have to gain the trust of the patient. So what we do is we try to remove any barriers that could be in the way, because being a nursing student is bad enough as it is. The only thing worse than a nursing student is a medical student. It's the truth. Patients are not excited to see either. They're okay when it comes to talking to you. You'll find the patients are giddy to talk to nursing students. But they don't really want you to touch them until they trust you. So we try to set you up to go in looking as trustworthy as humanly possible. Make sense? It's not punitive. It's there to foster communication. Eye contact. Yes, what you all frantically avoid whenever I ask a question in class. It indicates you're willing to participate in the conversation. So when everyone in the room is doing this, I know that nobody read what we're talking about for the day. Sometimes it's culturally inappropriate and aggressively seeking eye contact when you're right. You don't have to do that. If the client's not comfortable looking you in the eye, that's fine. But if you're the one avoiding eye contact, that's an issue. So make sure that you're working on making a connection with your patients. Do you see nurses walk in and go, hey, my name is Julie, I'm going to be your nurse for the day. Call me if you need me. Is that effective communication? Do we even know if the target of communication got the message? No, we don't. Because communication is a multi-part thing, and that's a test question sort of thing. Gestures, touching in personal space. Everybody has their own bubble, and everybody's bubble is a different size. So if you sit next to a patient and they move all the way to the other side of their bed, you know you're in their bubble, and you can scoot back some. Sometimes patients will reach out for you. What kind of touch is appropriate in a clinical setting?
Like maybe pat on the arm.
Okay.
Something.
Yes. Hand on neutral body part.
And then if you're going to go anywhere else, I'm going to do such and such exam. I need to do it. Is it okay if I put my hands here? So.
Tell them exactly what you're going to do. And as a general rule, start from the least invasive or the least private place and work towards the most private place. So if you need to do an abdominal assessment and Foley care, I would start with the abdominal assessment and then move south. Instead of just jumping right in there, hands under the crotch first thing. Let them build a little trust in you before you go for the most private parts of what you have to do for the day. Does that make sense? Okay. So things that influence communication. How old your patient is, what mental or developmental stage they're in, how they perceive you, how you perceive them, gender. You may have patients that will say, I will only allow females in the room, or I will only allow males in the room. It's not a judgment on you. It's a patient preference. Sometimes it's cultural, sometimes it's religious, sometimes it stems from previous bad experiences and PTSD. Do you argue with them? Well, I'm your nurse, so you just need to get over it. What do we do?
You can change the silence.
First thing is we acknowledge, okay, I hear that you're saying that you really want to work with a male clinician, so let me go see what we can do to rearrange the load so that we can accommodate you, okay? Even if we can't make a male magically appear, by indicating to the patient that you've heard what they need and you're working towards making that happen, you've already laid good groundwork. Instead of just, do they ever want to see you again after that? No. If you can't get what they ask for, sometimes just sitting down at the bedside and saying, hey, I hear your request. Can you tell me why? Is it something that, we can work with a male for this part of your care and have me do the rest if we have to borrow someone from a different floor and they can't stay the whole shift? Or is it, something that really you can't be in, they won't deal with it, full stop. So understanding the reason and asking in a sensitive way is really important. Does instead of just being like, she's such a bitch, she won't let me in the room. Well, let's find out why. So there are lots of relationships, and we've identified these already. What happens when people find out you're a nurse? Or a nursing student? Hey, I've got this rash! How many of you have that happen yet? Somebody starts talking to you about their problems and pulling their clothing back to reveal things you don't really want to see. It'll happen. If it hasn't happened yet, you've got 2 more semesters of this.
I usually get like, oh, you're in nursing school? When are you graduating?
Can you tell me what I should do about? And people will start asking you for free advice, which is why on vacation I always tell people I'm an accountant. No one wants to talk about accounting. So therapeutic communication is any time we're having a conversation that's designed to establish and build a relationship with the patient. We're building rapport so that we can provide better patient care. Okay? Needless to say, being caring, concerned, and empathetic is the way that we should go about it. What does empathetic mean? That's one of those big doctor words. So Rob, you're a doctor word man. Go for it.
I try not to be. I guess when you can, I don't know how to feel for the patient. When you can, I don't know, like what they're going through. You know what I mean? You can convey that. You know, you're there with them. You know,
Yes.
You understand what they're going through, and you have the ability to convey that to them.
Yes.
Best I can say.
Understanding that you can see what it would be like to be in their position. I feel for you. I get it. I get how awful this is. And I really want to help make it better. That's empathy. Do you get a lot of empathy in nursing school?
No.
So, the key to therapeutic relationships is gaining the trust of the patient, making them understand and believe that you really do want to help them, and being respectful. That's super easy when you have an easy patient. But how does this work when you have a patient that's a complete jerk? Does it go well? Can you build a therapeutic relationship with a patient who's a complete creep? Yeah, you can. How are we going to go about it?
Sometimes if they are upset because of their pain medicine,
Okay.
you work through it, just explain to them. I know they can be. If you tell them their pain medication is due every 6 hours, but they want it like every 2 hours,
Mm-hmm.
and when the doctor, just say, you know, we'll talk to the doctor when the doctor comes in if they can change their order.
Okay.
Or I'll write the time when the pain medicine is due on the board,
Okay.
so you know the next dose.
It feels like being angry right now. Who wants to be my angry patient? Who needs to let
Right.
something out?
Krista.
You wanna?
You want me to be the angry patient?
Yeah, I want you to be the angry patient.
You're just so good.
I'm a good actress, yes.
Yes,
Hi, my name is Emily. I'll be
What
your
do you
nurse
want?
today.
What? I don't want you in here.
Okay.
Can you go? I just can't deal with being here anymore.
Oh gosh, it seems like you're really frustrated about being here.
You nurses don't know what you're doing. I don't understand why you guys keep coming in my room.
There are a lot of people that come and go during a shift, and I can tell you're really.
But you guys just want to
unhappy
keep
with
waking
being
me up
here.
every hour. You just come in here just to bug me.
It sure does seem like that, doesn't it? The worst place to sleep is a hospital, and I can tell you're not very happy right now. Tell me what I can do to make things better. I can't
Just
change
go.
what's
Just go.
happened.
Just go. Just go.
Are you comfortable in the bed?
Does it matter?
Yeah, it matters a lot to me.
I don't think it does.
That's why I'm here. Are you having any pain?
Well, of course. You know, I just had surgery.
Yeah. Well, I'd like to make the pain better. Can you tell me where it is?
It's just all over. It's just everything.
Sometimes it feels like that, doesn't it? You've got some medicine ordered, and I'd be happy to bring it to you.
Are there other
Can you do it
things-
right now?
Yeah. Are there other things I can bring you with your pain medicine?
Well, I've been asking for juice. I've been asking to have something to eat.
Okay. Is there something specific you'd like me to bring you to eat?
I want a sandwich.
Okay. So I'll be back in about 5 minutes with some pain medicine, some juice, and a sandwich, and we'll see what else we can do to make you more
Are you sure you're going to
comfortable.
come back? Because that's what the night nurse said all night. She was coming back.
Pinky swear. I'll be back.
Okay.
Okay? And then once we
Don't
get
break
you
the pinky
fed,
swear. If
Don't
you
break
break the
the
pinky
pinky
swear,
swear.
it's over.
I'll bring you your juice and your food, and then we'll schedule some time for you to get a solid nap in between things, okay?
Okay.
All right. So,
She was pretty pissed off. Did I talk her off the ledge a little bit? As long as I come back in 5 minutes with the sandwich, juice, and some medicine, I'm good. I pretty much got her in a sweet spot where I can say, I hear that you need some sleep, so I'm gonna put a sign on your door, and we're gonna give you a solid nap. I won't let anybody come in and disturb you. Reasonable? Did I let her suck me into her anger and start get defensive? Well, that's not why we wake you up.
This is a hospital, it's not a hotel.
Exactly. Did I get mad about it? Is she mad at me? No. She's mad at the situation. And she has no control over the situation. And that's what drives anger. 9 times out of 10 in patients. They have no control. And all they want is for someone to help them feel like they can get things that they need. That's all they want. But like she said, people keep breaking promises. So if you say you're going to do something, be true to your word. If you can't make it happen, you need to go in the room and tell them, the pharmacy hasn't stocked the drawer yet. I am sorry. They're bringing medicine up. It will be another 5 minutes. I have not forgotten you. I will give you the medicine as soon as I have some to give. That's all you have to do. It's not so hard, right? So why do people keep screwing it up?
Because that takes time. That's going to take more of your time, and they
It
don't
takes
want to deal
time.
with it.
And it takes empathy, and it takes a little chip of you. You have to give a little bit of you in that interaction. So for people who are burned out, sick of their job, sick patients, sometimes they just aren't willing to put any more effort in than, I'm here, here's your pills. Don't ring your call light unless you're dying. I have other patients. You seen a Progressive commercial with Janice on the exercycle where she's refusing to talk? I'm blasting my quads. Cycling is my passion. That to me is the epitome of the disinterested nurse who's just like, stop. I don't want to deal with you. If you get to that point in your life, you need to take a break and find a change in career for a little while. So, active listening. How many of those things did I do just now when I was talking to angry Krista?
Normal, Krista? You did normal.
Was I facing her?
Yes.
Posture open? Make eye contact? Was I leaning in? Was I relaxed? My arms crossed? Just bunched up? So, this is gonna sound like I'm demeaning patients. I don't mean to. But it's a lot like dealing with toddlers. You've got to get down to their level instead of talking up above them. You've got to be calm and relaxed, and you've got to very patiently explain, very simply, this is why. I know that you want waffles right now, but we don't have any waffles. What we do have is a Pop-Tart, or a granola bar, or a pancake. And you can have any of these three things. We don't have waffles! Is that helpful? Is that useful? Is that therapeutic?
No.
Okay. So do that. The goal in all of this is to share a little bit of humanity with your patient, just a little bit. Not all of it, just a little bit. You get to keep some of your soul for yourself, just a little bit. So, the tentative tone part, what does that mean? What's a tentative tone? Let's go back to when I talked to angry Kristen. Hey, it seems like you're upset. That's a tentative tone. Hey, it seems like you're upset. That's a firm tone. Hey, it seems like you're upset. That's a questioning tone. So, hey, it seems like there's more going on. That's a tentative tone. And that gives the patient an opportunity to express themselves without feeling like they're in trouble. And that's what they need, because if they feel like you're pissed off at them and they're in trouble, they're not going to open up, and the rest of your shift is going to be a nightmare. Open-ended questions. You want pain medicine? Okay, what else can I do for you? What else would make you feel happy? A nap and a snack. Okay, cool. See how much it is like toddlers? She wants her juice and a snack and a nap. Dude, I'm all over this. Gentle, supportive touch with pinky swear, right? Didn't have to shake on it. Choose your touch by the age and the activity of the patient. If it's an older person who you think has no idea what a pinky swear is, don't do a pinky swear. You can put your hand on theirs and say, I gave you my word. I will be back. I even go as far as to say it's 9:54. I gave you my word, I'll be back in this room at 10 o'clock. Okay, now they have a concrete number, they can sit and watch that clock. And unless my hair catches on fire, I'll be back in that room at 10 o'clock. Using silence. Asking a question and then just giving the patient a chance to think about it before they respond. Or if they give you a snappy, angry response, letting it just hang for a minute before you rebut it with something. Usually if you get a really nasty response and you just sit for a minute, patients get embarrassed by how they've behaved. And they'll say, I didn't mean to. It's not your fault. But if you jump back right in with, why are you yelling at me? Well, now you've escalated the battle. Clarifying, you want a snack. What kind of a snack? She wants a sandwich, okay? Focusing on the key things. She wants pain meds, she wants a nap, she wants some food. Cool. Briefly restating, okay, so I'm gonna bring you back pain meds, juice, and a sandwich. Have I gotten the full message across? This is what you've asked me, this is what I'm gonna do. That's communication, that's the full communication cycle. Okay, sometimes we do some self-disclosure. What would be an example of self-disclosure in communication?
If you've had the same experience that I've also had knee surgery, or I've also, so I, you know what I mean?
had my appendix out too, so yeah, I know how uncomfortable it is. I feel for you. I got through it though, and I know some things that might make you feel more comfortable too, so let's work together to make this shift a little bit better for Make it a team thing. Involve them in it. Use the words. We'll work together so that they're part of the activity. And that part of communication can really shift the whole dynamic in the room. And acknowledging. I could have thanked her for, thank you for being open enough to tell me what you needed and why you were frustrated. Because I could tell you were really upset. And I'm grateful you trusted me enough to let me know how to make it better. It never hurts to tell people that you recognize they made themselves vulnerable. And that helped you do your job better. Cool with that? Okay, assertive communication. Sometimes this is talking to patients, but mostly it's talking to coworkers. What is assertive communication? What's the line between assertive communication and just being a wench?
Like you don't get angry with a person.
Right?
You're just being direct and honest.
You don't make it personal.
Yeah.
And that's the biggest part of it. You don't take it to a personal level. I hear that you need help with your dressing change, but I'm in the middle of a sterile procedure and I can't leave right now. So you can get someone else to help you, or I can be there in 10 minutes. That's assertive communication. I have set a limit. This is what I'm doing. This is the time I need for it. And these are your choices. You can wait, or you can go find somebody else. How about when you're dealing with a doctor? How are you assertive when you communicate with a physician? Have you dreamed, you dared to dream of such a thing yet? How do you assertively communicate with a physician?
For example, if you're in a patient's room and the doctor wants you right away,
Mm-hmm.
but you're busy with the patient, you cannot leave the patient and be with the doctor. So you can call for the charge nurse to come and finish what you're doing, or the charge nurse can go and talk to the doctor and help the doctor
Okay.
see what he needs.
So how are you going to let the doctor know that you're not leaving the room?
You can explain, I'm doing a dressing change right now.
Okay.
I cannot just leave the patient all day.
And you're saying that so softly and gently.
Yeah, I'm in the middle of a dressing change.
I recognize your time is valuable, but I cannot leave what I'm doing. I'll be with you as soon as I'm finished. It is what it is. You don't have to be rude, but you need to clearly state your limits. And that's what assertive communication is about. If you're not comfortable with setting boundaries and setting limits, you need to start working on that at home. Non-therapeutic techniques. So these are things that would be wrong answers to test questions. Anything that stereotypes a patient, anything that's a defensive response. Well, it's not my fault. Probing. Are you always this much of a bitch? Challenging. Oh, I dare you to get out of bed and do that. Rejecting. I don't have time for you. Asking personal questions. Do you live your life like this? Those are non-therapeutic techniques. Okay. Using jargon. Can you think of any jargon that might be offensive to a patient? It might not be something you say directly to the patient, maybe something you say amongst nurses. Oh, she's such a PETA. Remember that one? Pain in the ass. Yeah, that's jargon. That's not appropriate. It's not acceptable. Even if they are PETA. Changing the subject. Your patient's trying to tell you something and you cut them off. because you think what you have to say is more important. It's not therapeutic. Blaming a patient? Well, if you hadn't gotten pregnant 7 times in 8 years, you wouldn't. Okay. What's the difference between reflective talk and parroting? Patient says, I'm so scared. I'm so scared. That's parroting. Sympathy versus empathy. What's the difference in the two?
Like, I don't know, like, oh, you poor baby, Gucci Poochie, like that, yeah.
Yes. Pity versus understanding. That's the major difference here. Passing judgment, giving personal opinions. I think if you would just stop sleeping around, okay. False reassurance, I'm sure it'll be just fine. So there are barriers to communication in elderly patients. Aphasia, they can't speak. Dysphagia, can't swallow or speak well. Confusion, dementia, sensory loss. So the first thing that we may need to do is to find out exactly how well they're able to see or to hear us. Does that mean you walk in the room with your elderly patients and immediately talk like this? Why is she yelling at me? Find out if they have deficit first and then work with it. People with sensory impairment tend to feel like they're isolated from what's going on around them, especially with hearing. You can't hear what everybody's saying. They're talking, they're having fun, but you can't hear, so you're not a part of it. And you start to feel really lonely and isolated. So they may avoid interacting with you, or if it's in a group setting, they may avoid interacting like in a day room in a psych unit. That's not good. Communication can be misunderstood, so you need to find out what your patient's preference is. If they're hearing impaired, do they lip read? Do they need to watch you directly when you talk? Do they want you to write things? Do they have a hearing aid that's in the nightstand and you need to get it out and turn it on, put it in so they can understand you? And sometimes people with visual impairment can't tell facial cues, so everything is based on tone of voice. And that's one of the times it's super important to make sure that you're using a neutral tone of voice or a tentative tone of voice so that they don't feel like you're passing judgment or you're angry. Sometimes we have to provide adaptation for older folks. We want everyone to be able to receive and send messages clearly, to feel that they're expressing their needs and that we're understanding them and they get what they need in return. So, if you are prepared to speak in front of a group of your peers, what type of communication are you using? I would say group. When we talk about interpersonal, we're usually talking about 1 or 2 people that you're talking to, like a small cluster. Interpersonal is nurse to patient. Intrapersonal is nurse to nurse. Oh, I really need to go change this dressing, but this patient needs their pain medicine. Yeah, I should do that first. The voice in your head that narrates what you're doing with your day. That's the intrapersonal. Organizational is things like establishing communication guidelines for an agency, like hospital policy, hospital handouts. That's organizational communication. Which of the following activities occurs during the orientation phase of the helping relationship? What's a helping relationship? That's a nurse-patient interaction. What's the orientation phase of that? The end? Middle?
Beginning.
A beginning. So, what activity happens at the beginning of an interaction between nurse and patient? That's what the question wants from you. Your options are an agreement or contract about the relationship is established. The nurse provides any assistance needed to achieve patient goals. The nurse provides patient counseling and teaching. Okay, when would we provide patient counseling and teaching? At the beginning, the middle, or the end of a relationship?
The end,
Towards the end. How about assistance needed to achieve goals?
the middle.
Middle. An agreement or contract about the relationship.
The
That's
beginning.
the beginning. So that's a weird phrase, but all that means is you've established, hi, I'm your nurse, and I'm going to take care of you. I need you to let me know what your needs are.
See, I guess that's though how you read the question. Me,
Uh-huh.
personally, I read the C, you're, okay, so you rate, don't work the patient. The first thing you're doing, you're counseling and teaching, and then you're helping them, assist them to achieve those goals you just taught and counseled with, and then okay, so this is our agreement. That's how I read the question.
Okay,
You know what I mean?
this is why it's important for you to come to class today.
Exactly. So now I see, and I understand what you mean by the agreement, contract, and initial. Okay.
This is why I said this was an important class for folks to be at.
I don't know if anyone else read it that way, but that's how I read it at first before.
Totally cool. That's why I'm here to explain the way these questions work. An open-ended question or comment serves to validate what you believe is heard or observed. So tell me how that would work. Angry Krista, it sounds like you're hurting and you're hungry and you're thirsty. That's an open-ended question. Are there other things that you need? Okay. That gives me validation on what I think Angry Krista's needs are. Make sense? Okay. A nurse who fails to log off a computer after charting has breached patient confidentiality. True or false? True. Absolutely true. Anytime you leave a chart open and unattended, and that means a paper chart on a desk, a paper chart in a room, an EMR on a computer on wheels, a computer logged in at the nurse's station, open to a chart, anytime you walk away from that, you're breaching patient confidentiality. Oops. So you see this happen all day at the hospital. But I'm here to teach you that on the NCLEX, that's not something you're allowed to do. The patient's looking out the window with his back to the door. The nurse opens the door and says, "You won't be able to eat or drink after supper because of tests tomorrow," and leaves. Was that communication?
No.
Why not?
Eye contact.
So our content.
Do we have a sender?
Yeah, the nurse.
Yeah, we have a sender, we have a nurse. Do we have a recipient?
Next question.
We have an intended recipient. Do we know if the message was received?
No.
We don't know if the patient received the message. Therefore, there can't be any understanding and agreement. So this wasn't communication. We had a sender, but we don't know if we had a receiver. And we sure as heck don't know if they got the message. So if you went back and charted that patient was instructed not to, well, I told them. But did you communicate it following the rules of communication? No. And that's what you need to know for the test. Communication requires a sender, a recipient, and an understood message. If you delegate something to someone, I think we have a question. Maybe, okay, we'll do this one. I'll come back to the thought. When you're performing a nursing procedure on a patient, which of these is true? Should you always have someone witness the procedure, avoid eye contact to reduce embarrassment, be aware of your own nonverbal messages, or only listen to what the client says?
See.
Be aware of his or her own.
When would A be true?
If it was a child?
Or like if you're doing the opposite sex.
Okay, yeah, if you're doing like a male putting a Foley catheter to a female, guys usually don't care about female nurses putting in Foley catheters, but if they indicate any discomfort, then yes, get someone to come and be a witness. So we only have to have a witness if it's a procedure that's intimate in any way. Make sense? So that's not always is a word we avoid. Remember? Avoid eye contact to reduce embarrassment. If I come in and I'm doing a wound change, dressing change on you, and I won't look at you, how does that make you feel? Do you feel like I'm comfortable taking care of that wound?
No.
Does it start seeming a little bit creepy and awkward that I won't look at you? You're like, do I smell? Like, what's wrong? So, avoiding eye contact to reduce embarrassment doesn't work. Do you have to make eye contact in the middle of a pelvic exam? No. Your gaze should be focused on your activity. But you make eye contact before and you make eye contact after. You don't avoid it entirely. Be aware of your own nonverbal messages. I'm sending a pretty loud nonverbal message with my dressing change, right? Just be aware. Don't be like, it doesn't make patients feel bad. Only listen to what the client says. This one, how many of you read that answer as thinking about what family members would say instead? This one's meant to convey that you should only listen to what they say and not pay attention to nonverbal cues. Did you read that answer that way? Yeah.
I read it as like, oh, I'm good, that's good, yeah, good.
Uh-huh. This one means you have to pay attention to their nonverbal cues as well. Make sense now? Okay. Communication is tricky. The test questions are tricky. When you're interacting with a patient, the nurse answers, I'm sure everything will be fine, you have nothing to worry about. Which type of inappropriate communication is this?
Giving advice.
False reassurance, right?
False reassurance ain't an answer, Ingrid.
I know. When you said that, I'm looking at it.
Rob's like, is there something with my story?
Because I'd agree with you.
Like you're giving advice.
Are you giving advice?
Yes,
Because you're saying
it's gonna be fine.
to work.
Well, I think
Advice
advice
is
would be
telling
like,
you how
yeah.
to do something.
Oh.
So if you just stop sleeping around, I'm sure everything will be fine. That's giving advice.
So changing the subject?
Maybe-
Changing the subject would be, what would you like for lunch today?
Being judgmental.
being judgmental because it's
If
your
you weren't
judgment.
such a hoe, you wouldn't be here.
Oh,
It's
it
cliche.
Man, we're all
This
Oh.
is a cliche.
Fail. Throw that question out.
So, remember, giving advice is telling them what to do. Did you tell them what to do?
No.
No, you blew them off. Being judgmental. Did you tell them what you think they were doing wrong? Did you moralize? Did you give them a sermon? No. Changing the subject means moving completely away from the topic. You're still talking about their issue. You're just blowing them off. Changing the subject is, do you want the hamburger or the pork chop for lunch? Got it? Cool. Okay, so now let's talk about, I thought there was going to be a slide about delegation, but it must be on the, yeah, it is on this list. Okay. So when you delegate things, and I know you're not used to delegating yet because everything is being delegated to you at this point, you will get NCLEX questions about delegation. What are the things that you have to know before you can delegate a task to someone else as an RN?
Their scope of practice,
Their scope of practice.
their level of that they can do the task.
Can they do it or not?
And if the state or wherever you live allows, you know.
Is it allowable? Right. So, if you're delegating a task, is it enough to say, Krista, I need you to take vital signs on all my patients this morning and consider that a task that's been delegated? That's a test question. Was that enough to have delegated a task?
No, because you don't know if she's ever taken vital signs.
We have several problems here. Did Krista respond?
No.
Nope. So, because she didn't answer me, I have not delegated that task. Delegation requires you to pick someone with an appropriate scope of practice that's able to do the task, who accepts the task, and you set a boundary for anything unusual. And I need you to come tell me if any patient has abnormal vital signs. Krista says, okay. I have now delegated that task fully. So if she takes vital signs and they're abnormal and she fails to come tell me, it's not my fault. It's hers. I fully delegated the task. I did everything the way I was supposed to as an RN. Make sense? Cool with that? So you have to have them acknowledge what they're supposed to do and set a boundary as well. You good with that? All right, now let's go to our list.
Aren't most test questions like, which task would you delegate?
They can be, but it doesn't mean that you won't get questions that are different. So what tasks do you delegate? What do you delegate to techs?
Vital signs, turning.
Stable patients only. Only stable patients. You got that? So they can do basic tasks on stable patients. Hourly INOs, can I delegate that to a tech? No. If you need hourly INOs, you are not stable. That is not delegatable to a tech on the NCLEX. Per shift INOs? Yes. That's a stable patient. So anything that requires very close monitoring means they're unstable, and you don't delegate that to a tech on the NCLEX. Hourly blood sugars. Should I delegate that to a tech?
No.
No. Could I delegate that to an LVN? Yes, because it's within their scope of practice to get a result, see that it's abnormal, and come and get me to do something about it. They have a license that says that's within their scope of practice to do. Can you let them manage the abnormal blood sugars?
No.
No, you cannot. But you can delegate the monitoring. Those hourly INOs, you can delegate that to an LVN. This is someone with a higher level of education and a license. They can do that. They can do uncomplicated tasks on unstable patients or complicated tasks on stable patients. So a sterile wound dressing change on a stable patient could be delegated to an LVN. Make sense? It's a complex task, but the patient is stable. Could I delegate trach suctioning on a patient who's just been placed on a ventilator to an LVN? Because that's an unstable patient. In an LTAC, a patient who's been vented for 6 months, can I delegate trach suctioning to an LVN now?
Understand?
Yes, because now that's a stable patient. That makes sense? It's really important to get that clear in your head that techs do uncomplicated things on stable patients. LVNs can do complicated things on unstable, or uncomplicated things on unstable. And everything else you own. You got it? That's one of the hardest parts of nursing school to really get. You're an LVN on the night shift working on a med-surg unit. You've got 2 RNs, a tech, and yourself. You're assigned to a 6-hour post-op patient who's anxious, restless, and can't settle down to sleep. You ask him about pain, he says he doesn't have it. You ask one of the nurses what to do. The RN tells you just to keep an eye on him. Is that very concrete details on what you should do? What does just keeping an eye on someone involve?
Still there.
Just check
Yep,
on him
in
every
bed.
whenever.
Yep. Haven't left yet. Yep, he's there. So the oncoming RN finds him with a very low O2 sat, a low blood pressure, and a high heart rate. What went wrong with the delegation here?
There wasn't clear and concise.
We didn't give clear instructions and we didn't give parameters. So the RN said to the LVN, monitor the patient, but she didn't say, and if his vital signs become abnormal, come and tell me. So the RN is at fault more than the LVN here. Does that make sense? This was a fresh post-op patient. As long as they were stable, it's okay for the LVN to have them, but the minute they become unstable, they go back to the RN's care. The RN did not make that clear. You ask student nurse Tim to remove Mr. Lane's peripheral IV prior to discharge. Tim has removed IVs before. Half an hour later, Mr. Lane's doctor is at the nurse's station and he is raging because Mr. Lane's PICC line has been removed. Who is responsible?
You.
The RN. What should have been done differently?
Like maybe stay with the student nurse while
Yeah.
he's about to remove.
At the very least, you take him by the hand into the room and you say, you're going to take this one right here out, okay? All right, good. We got it. So just telling him to go and take out an IV is not clear direction. He saw a line, he pulled it out. By gum, ain't the longest IV I've ever seen. He was following what he understood from your delegation. Your delegation was not specific enough. You take the IV from his left hand and nothing else. And if you've never worked with student nurse Tim before, would you turn him loose on his own to do it? Let me come with you and watch your style. We're just going to be here in the corner. I want to be sure he can do it without, I've seen things that would make a corpse rise over the years. You don't turn somebody loose to do anything that could be a break in aseptic technique without knowing that they can do it without breaking aseptic technique. Tim goes in there, no gloves, digs an open Band-Aid out of his pocket, slaps it on. I mean, where is your faculty? Good. See right here. Sarah is a new tech on your unit. You have not been assigned with her before. You have a new patient that needs a urinary catheter inserted. They are on your unit tech skills checklist. What else do you need to know before you can delegate that catheter to Sarah?
Has she been trained on it? Has she done it before?
Has she been trained on it?
Does she feel
Has done it
comfortable?
Has she been
before?
checked off?
She's been checked off. Does anybody on this unit see you do it? How many of them have you done?
Yeah.
Do you feel comfortable doing it? Do you know when to come get me? You make one try and you don't hit what you need to hit. You come get me. You don't go 4 boxes deep digging around, okay? Because I've seen people try and miss and pull that same dirty catheter back and try and miss and keep going for 5-10 minutes. No, you can't do that. You ask a tech to take and chart vital signs on your patients. It's been a very busy day and you have not seen them for most of the shift. You make rounds here at the end of your shift, you notice that one of your patients has had a very high blood pressure since the morning. Did you screw up?
Yeah.
What did we forget to do?
Forgot
You
to
should have
say.
been checking the vitals too. I mean, if it's, you're supposed to go through, right?
No, she forgot to tell the tech.
To tell
Come
them that.
tell
We
me.
didn't fully delegate the task. We did not say, and anything out of range for that patient. You come find me immediately. Not just you chart it,
Yeah.
because that's what we gave them permission to do. We gave them permission to only be responsible for taking and recording and for nothing else, which means we should have been watching the computer all day,
Yeah.
and we weren't. So it's on us. If your patient always has vital signs that are out of range, it's okay to tell the tech if their vital signs are out of normal for them, come and tell me. Like if your patient's been 160 over 85 to 170 over 90 for the last week, do they need to come tell you every 4 hours, hey, it's 167 over 88? No. But if they've been 167 over 90 and all of a sudden their blood pressure is 82 over 40, you need to tear a strip off. Getting to me. Let's hustle this as a crisis. So anything out of the patient's norm needs to be reported. That's a major part of delegation, and that's where most people screw up. You've been floated to the surgical unit. One of the patients needs a procedure done that's on the tech checklist for the unit, but it's a sterile, invasive procedure. You don't know the tech, you don't know the patient, and you don't feel comfortable sending the unknown tech into the unknown patient. And the charge nurse tells you, don't be a baby. Do it all the time. What should you do?
Your patient, your responsibility, you do it.
Your license. If you like your license, take the tech in with you. Let's do this together. You can let the tech do it in front of you with your assistants. Then you know whether you can trust them to do it in the future. Plus, it's a new patient. Do you want that new patient to be like, I don't even get a nurse, I just get a tech? I don't even get to meet the nurse, I just get a tech? Where am I? Is this like the 7-Eleven hospital? What the heck? So if you don't know somebody's ability, you don't have to trust someone telling you, stop being a baby. It's your license. The NCLEX answer is, either you do it yourself or you go with them. Make sense? Don't just be like, oh, well, she said it was fine, so I hope it's all right. Because that charge nurse is going to turn around and say, I never told her that. Loses her license. You. Womp womp. Do you feel like it was worthwhile to come in today and do communication? Okay, glory hallelujah, I'm glad. Because it really is more complicated than people think. Students look at it and go, it's just communication. I've been talking to people my whole life. Yeah. It's a little bit different than just having a chat. All right, do you have questions for me about this stuff?